about that early on. So, it's very, and as a med student and as an early resident, you have sometimes the closest, time frame to your medical training. Some attendings have been out, and I'm already forgetting a lot of medical specifics that I learned. So it's always, you always have valuable things to add, and don't ever be afraid to speak up. A thorough evaluation of any patient is important. So, the history, a lot of the time, I see people in the office now, and it's an old person who's been in the house all day, and they want to tell you how their shoulder pain has evolved over the last 15 years, and they have specific details, and you have 5 minutes to get through your history and physical. So, sometimes you kind of have to rush through things, but especially when there's any sort of injury, you want to get, you want to get a basic concept of how this happened. Is it high energy? Is it low energy? Is it a slip and fall? Is it a motor vehicle accident? Were they hit by a car? Because a lot of those things are very important, and it's not just the question isn't just is it what's broken? Is it a tibia fracture? But how was it broken? And does the mechanism of injury make sense? Because that's kind of important in picking up sometimes pathologic fractures or say my baby fell and broke his leg. Well, my baby's 5 months old and can't walk. So sometimes these things are very important to pick up. And then the duration of the condition or timing of the injury is also important, because that's also just relevant to how do you treat people. That may not be just in the hospital, but in the office. Somebody that's living with a problem for a while is going to be, they're going to want to approach it differently than somebody who just had an acute rotator cuff tear or an acute fracture and we're otherwise very healthy and active. So these are important things to think about. Where is it hurt? What does the pain feel like? These are all things that are, you have to, it's difficult to sometimes direct people, but you want to get an idea of the character of the pain. Does it shoot up the arm? Does it shoot into a certain distribution? These are all things where your anatomy and your knowledge of nerve distributions and how different muscles work is very important. And you also want to understand what did the patient do in the past? How have they approached this problem before? Does anything else hurt? Because you may be called for femur fracture, and you may miss a minimally displaced ankle fracture or something. It's always important to, as best you can do, be thorough and get, you don't want to miss something important that the patient may not easily volunteer. Past medical history, surgical history, and history of smoking, drug use. These are all things important to guide your treatment, and also just to know about. You'll see later on, it's important to be able to document reasons why the patient may not do well later on. It's not just medical legal. You want to be able to tell the patient, well, you smoke. Well, it's very important that you stop smoking. And if you don't stop smoking, this is what may happen to you. This is how your condition may evolve. So definitely important to get a sense of also history of heart disease, patients on blood thinners, history of stroke, history of weakness. These are all things that are important to know about, because they may affect the patient's fitness for surgery. Also, history of any sort of autoimmune problems, which may make them more prone to infection. If they're on any immunosuppressants, these can also make them more prone to poor wound healing. Diabetes for sure can make them prone to poor wound healing. And also, does the patient have any sort of history of thrombosis, or are they at risk of blood clots? All things to know about prior to making a recommendation for how to treat somebody. Examination is important to be, we're not realistically going to go in there and, auscultate the patient's lungs and see, well, is there, are their breath sounds exactly the same? I mean, I'd be lying if I said I really had that, or I could appreciate, the nuances of all these different heart murmurs. But, I think it's important to not lose track of, is the patient sick or are they not sick? And, know how to read a chest x-ray, know how to, evaluate, and, just don't miss something, that if the patient looks sick, you don't want to be glossing over things and just focused on the one distracting injury, because you can miss You can easily miss other things. It happens to everybody. It doesn't mean that it's okay. It doesn't mean that you shouldn't try to avoid it, but missing associated injuries is very common, especially in the polytrauma patients that you'll see here. Um, Hemodynamic stability, is the patient stable? These are also very important for trauma patients and sick people if they have a septic joint or other, or if they're just, old and, are in poor state of health in general. These are all things to know about. Joint above, joint below. These are just kind of basics, in terms of looking at a long bone fracture. You want to make sure that there's no dislocation that's next to, joint above, joint below, and really the entire limb. You want to palpate, see if anything's loose, see if there's any crepitus. You don't need an X-ray to get suspicion for a fracture. So these are things that are, don't be afraid to lay your hands on a patient and push. And if it hurts, you need to know about it. And you're not doing things to make somebody hurt. You're not doing it on purpose, but you certainly don't want to miss something. The patient can't always tell you exactly what's wrong with them. So, we kind of start with physical exams. You start with looking. Is there deformity? Is the skin intact? Is there a rash? Is there redness? Is there swelling? So you can just, is the limb crooked? Is the foot pointing the right way? These are all things that you want to just look first. Look before you touch. Look before you leap. I think it's always, good to just get a sense of what the patient looks like. Vascular exam is important. I think it's basic. You got to check pulses. Really, any sort of orthopedic consult. You just never, even if it's an old injury, you can easily get a sense of whether the patient has peripheral vascular problem by palpating pulses, and especially if there's asymmetry. And if there isn't asymmetry, if you can't feel any pulses anywhere, well, maybe the patient is hypotensive or they have significant PVD. But these are all things that are important to actually check and not just say, the patient has a 2+ pulse if you think that they're perfused. Sensory exam, especially if there's a particular nerve that may be injured with a certain fracture, very important to check the nerves, all the nerves in that extremity, and see if there's any sort of difference in the sensation. Motor exam is important. It's tough to do if the patient has a fracture. Whereas an injury nearby, it's going to be difficult to do that. But as best as possible, you want to make sure the patient's firing the motor fibers that could be affected by a nerve that could be damaged in the injury. And then range of motion, that kind of goes without saying, especially if they're in the office. Active versus passive range of motion can check for joint contractures versus tendon injuries, especially in the shoulder. We examine this all the time when you're checking for a rotator cuff tear, frozen shoulder, glenohumeral arthritis. These are all things where range of motion is important to document what the patient has an active motion deficit or if everything is stiff. So you hate to say, one of the things that a lot of residents will kind of learn to say, and as a joke, but sometimes when you get consults that you're consulted for an injury, or pain, but there's no X-ray. No one is thought to order an X-ray. But the phrase like "no bone, no phone" gets thrown around. You can really tell a lot from an X-ray, and there are very few consults where I think an X-ray isn't indicated. It may not guide all of your treatment, but for example, you get a call for a swollen limb, Rule-out compartment syndrome. Well, how do you know that there isn't a fracture underneath without, especially the patient's obtunded? Like, how do you know that there's not something else that needs to be done in addition to a fasciotomy if you need to do one? So how do you know if there's not, any sort of gas in the soft tissues? You can tell a lot of things from or there's a bony infection. There's a lot of things you can tell with an X-ray. And we get plenty of CAT scans in the ER here. We don't always order them, but they're often available to us because the ER has already gotten them. These things are useful, but an X-ray quite often is just as, if not more useful than a CAT scan or advanced imaging or an MRI, ultrasound. So these things they can all be complements, but it's very rare to have a condition where you're not going to order an X-ray and you're not going to carefully examine it. And multiple views, especially for any sort of fracture or dislocation, because that's going to tell you, number of fracture fragments, displacement, what direction is it, how many pieces is it in, and finally skeletal maturity. You will probably be able to get a good idea about this based upon the age of the patient, but these are things that are, things important to identify, especially around when patients at puberty, because there are certain characteristic fractures that can happen around the growth plate, and those and there are certain things about the injury that you may know or maybe clued into offhand, especially around the ankle. Dr. McParland, I'm sure, knows more about this than I do, but these are there are certain characteristic injuries in kids that you want to be clued into just by looking at whether the growth plates are open, closed, or closing. So if there's a fracture, okay, obviously here proximal femur fracture. Where is it? First of all, what bone is broken? Okay, this sounds kind of simple, but this is how we describe it. So I would call this a displaced left intertrochanteric femur fracture. Okay, that really will kind of tell you over the phone without even looking at an X-ray. I can picture this image. Comminuted is in more than one piece. Fracture alignment. How is the bone properly aligned, or is it really out of place? Angulation, translation, shortening. Angulation is the bone with the two pieces pointing in the correct direction, or are they bent in a way that's funny? Translated, are they shifted in relation to one or the other? And shortening is whether the distal fragment is brought more proximal than it ought to be by the pull of adjacent muscles. These are all important, and certainly important is the joint surface involved, because that completely changes your, oftentimes completely changes your surgical approach and how you're going to approach treating the fracture if you're operating. In addition, you want to, so this X-ray versus this X-ray, well, there's a big difference here. A, not just because there's a fracture here, but B, this joint is completely eroded. There's flattening of the femoral head, there's cysts. These are all signs of degenerative joint disease, osteoarthritis. In adults, we deal with this a lot, in kids, not so much. But these are things to, especially, this is a really, bad arthritic hip. But earlier on, the joint surface narrowing might not be quite as severe, but you will certainly see in the hip, you can see certain things that can clue you into this patient may have a problem in the future. This patient has an early problem. How is the joint aligned? Is the joint varus or valgus, which has to do with the center of gravity and which way the joint is aligned, and then the keys of the hallmarks of osteoarthritis: osteophyte formation, joint space narrowing, subchondral cysts, and then subchondral sclerosis. So this patient's got 4 out of 4, obviously, but these are all things that if you're being asked to read an X-ray, especially in your joints rotation, these are all things that you want to call out. I guarantee you somebody will ask you, what are the 4 characteristics of arthritis on radiographs? So these are things you want to know about. And finally, when you're evaluating a patient and your resident or intern asks you to go see somebody and try and do a consult, don't ever call somebody, and especially as a resident too, don't ever call your senior or attending without at least having taken 5 minutes to read about it and come up with an assessment and a plan on your own. No one is going to drop dead or have a severe worsening of their problem in 3 to 5 minutes that it could take you to go online and do a quick Google search. This information is all at your fingertips, and just thinking about this and coming up with a plan, even if you're wrong, it just shows that you're interested, shows that you're trying to learn, as opposed to like asking, well, what do I do? Or sending an X-ray and saying, hey, like this is in the ER, without having seen the patient. These are all things that are a big no-no. And as senior residents, we would just lose it on our juniors when they hadn't evaluated the patient and they would call us about it, asking what to do, because that just shows shows that you're not really taking the consult seriously. So you really need to evaluate people and think about it. And most of the time, it's not too much of an effort to do this. So and I think it's very valuable for your own learning, especially if you've seen something before or you haven't seen this problem before. You learn a lot about things by thinking about it on your own, coming up with a differential diagnosis or a plan, and coming up and trying to think through it. Sorry. So here, the differential diagnosis, I'm assuming that they picked this image for a reason. Obviously, we look at this and we see a really badly comminuted displaced tibial shaft fracture and fibular shaft fracture. And you probably, if you weren't looking carefully, you might miss the distal femur fracture in the bone above. So, it's always important to carefully scrutinize these things. And obviously, you palpate the patient, you're probably going to see that the thigh bone is crooked. Well, just looking at an X-ray might be, if you're not being, careful and being systematic with your approach, you may not see this. So there is not always, oftentimes in orthopedics, we know what the problem is, but you always got to keep your mind open to other possibilities. And absolutely, have a recommendation, even if you're wrong. As a med student, as a resident, it's okay to be wrong. That's why you're in training, and that's why you have people that should be, there to educate you and back you up. And as long as you don't make the same mistakes repeatedly, and as long as you learn from your mistakes and you show an effort to get better, that's all anybody can ask on you. So be ready to discuss treatment and know the alternatives, and why do you think what you recommend is best. This is important in attending life, because patients have oftentimes read about the alternatives, and if they haven't read about them, sometimes they want to know, what are my choices, and do I need to have surgery? Do I not need to have surgery? Just because a patient broke a hip doesn't mean they need surgery, but they need to know what's going to happen if they don't have surgery. Likewise, with any injury, a patient might have that might require surgery. There's a predictable outcome if you don't have surgery, and there may be a predictable or may not be a predictable outcome if they choose to have surgery. So these are all things that help the patient feel comfortable and help you look competent in the eyes of the patient, rather than saying, well, you just need to have this fixed. So be prepared to talk about the different things that may be appropriate to do. So case number one, we're going to go through some cases here. So a 27-year-old guy with left ankle pain and deformity. So, history, I don't know, can we make this interactive at all? I don't know how easy it is to do over Zoom, but anybody want to take a stab at, like what's important here in the history for this patient?
How did it become deformed? What was the inciting incident?
Good. So how did this happen? Where did it happen? Anybody think about any sort of medical problems that or social history you might want to know about regarding a young guy with an ankle fracture?
Does he play any sports?
Good. What is his social history? What are his demands? After this heals, like does he want to get back to sports? How about any medical problems you might want to know about with lower extremity fractures? All right. History of diabetes is super important with anybody with, well, any fracture, but especially lower extremity. Younger people, maybe not so important, but especially as we get into our 40s and 50s and older, history of diabetes is super important, especially if it's poorly controlled, because these people are at very high risk of poor wound healing. So always important for lower extremity fractures, like is there a history of vascular disease, diabetes, very important. And then finally, in a young person who, you want to make sure that they're not on drugs, that they don't have a history of persistent drug use, any persistent alcohol use, things that could predispose them to either going to withdrawal or be, unreliable surgical candidate. These are all things to know about. All right. Examination, obviously, is it an open injury? Is it a closed injury? Is there a crepitus? Does it feel dislocated? How is there a problem with the knee? Are there wounds over the foot? These are, you really want to examine the whole extremity and make sure that there's no associated injuries. So I don't know. Looks like there's some notes down here. I'm not sure if there's we're missing, but X-rays here. Anybody want to take a stab at reading these x-rays?
I could try.
Go for it. No one is grading you, so this is your opportunity to kind of, take a stab at reading these.
All right. So this looks like a apine lateral of the left ankle joint in a 27-year-old male. With regards to the fracture, it looks like there's a distal tibial fracture that is comminuted, clearly comminuted. And looks like it's extending into the joint space.
Good.
Yeah.
Another thing for lower extremity, you always want to, try to comment on whether it's weight bearing or not. Obviously, this is, I hope it's not weight bearing. But yeah, that's important for lower extremity too. So yeah,
So-
but this is, and you can also get a sense on these X-rays. You see gas in the soft tissues, you see bone poking out of the skin. So these are things that are concerning for open fracture. There's displaced, the articular surface is displaced. The fibula is broken. So these are all things that you can, comment on your read. But yeah, it's a good job. Basically a displaced intra-articular distal tibiofibular fractures with joint surface impaction. And then also, is the talus centered under the tibial shaft? Because that is a, and is it shortened? Because you want to, if you're going to treat this surgically, especially if you're going to X-fix it, you want to restore that. Is there a reason to X-fix it? Does it need to be washed out? Does it need to be split in? If it's an open fracture, probably should do that. But these are all things that you want to get a sense of prior to recommending treatment. So, assessment of plan, diagnosis, we talked about it. So plan, well, firstly, your plan is, you're going to be generally the first line in the ER. So when we talk about open fractures, your first in a patient with this type of injury, your radar's got to go up. This is high energy. Like something happened to this guy. Like he was either run over by something, or he was fell off a bike or a scooter or something. Pretty high energy. So first and foremost, you want to check for associated injuries. Make sure that there's nothing else broken. Secondly, you want to make sure that his leg doesn't look like it's about to blow up with the compartment syndrome, because these are all things that you want to get your radar on and alert somebody early on. I'm worried about this patient versus this patient just has an open fracture, which is serious, but isn't an absolute emergency compared to other things. So these are all things to consider in your plan. But bottom line for this guy, I think you have to think about, how am I going to stabilize him in the trauma bay? Am I going to clean his wounds? Am I going to wash him out gently and splint him? And then how am I going to recommend treating him, urgently versus putting him on ice and adding him on for the next day. So these are all things to think about. Acuity of the injury. What do I do right now versus an hour from now versus, do I get additional X-rays? Do I get CT scans? I know that, here we do a good job of anytime we basically lay hands on a fracture or an acute injury, if you place a splint on it, we get X-rays. I think that's a good habit to get into as you get a little bit, I don't want to say older, but it's not always necessary to do that, but it's fine to get in a habit. And when these X-rays are readily accessible in the ER, it's probably a good idea. So what are some things that you guys think are things to consider in treatment of this injury? Any of the students, how would you does it need surgery, right? B, what type of surgery, and would you do this acutely? Would you stage it? What do you guys think about this?
Probably needs a reduction in compensation. Is it acutely or not acutely? I mean, I guess it would depend on any compromise of the vascular supply in the lower extremity and make it more acute. Otherwise, I'm not sure. I also want to be worried about injury, like you were mentioning before, like because it looks like a high, you know, high power injury, like maybe like additional injury later up, like in your leg or spine or something like that. So I want to check for that as well.
Yeah. So, you know, these are all, you know, that's all good. I think I heard about 50% of what you said because your microphone's not working too well, but yeah, you know, these are, you know, and pilon fractures, you know, we call this a pilon fracture where the joint surface of the distal tibia is impacted. And pilon is like French for hammer or something, but these are really bad. These are really bad news. And, you know, it's well known in the literature that these guys have a high complication rate in terms of wound breakdown. Obviously, I don't really do too many of these, but you know, we do deal with these even in hand surgery if you're on trauma call. You know, dealing with them acutely. So, you know, these are bad injuries, and oftentimes the soft tissues are not able to accommodate the incisions that you would need to do in order to, you know, put buttress plates on here and put locking plates on to stabilize these fragments. So, so oftentimes for, you know, especially for open distal tibia fractures like this, you're not ready to do your definitive fixation right away because the soft tissues are just too injured. So, you know, just for you guys' knowledge, you know, this oftentimes will not get definitive fixation early. Some people do talk about fixing pilon fractures with early if you can get to them in the first, you know, 16 to 24 hours if it's not too swollen. But in general, a bad fracture like this gets washed out and X-fixed, and then you know, once the swelling improves and the skin is ready, then you can talk about doing the, you know, additional fixation. But obviously, this needs to be fixed. Obviously, the mechanical axis is off. You can't leave this patient like this. All right, here's a different one. 7-year-old girl with right arm pain and deformity. So history, right? How did it happen? Does the mechanism make sense? Was she on the monkey bars? Did she get, you know, was she in a car accident? Or did she, you know, did she pick up her backpack and her arm broke and she has shoulder pain? Like these are all things that are important to know. You know, physical examination. Kids with supracondylar fractures. You know, we talk. You know, these are all there are characteristic nerve injuries that can happen with these fractures. So very important to document a good. You know, as best as possible. Kids are tough sometimes to get to cooperate with a physical exam, but generally you can get a decent sense of, are they moving their arm, they're moving their fingers, and can they feel you touching them? A 7-year-old, and the younger you get, the harder it is, but in general, a 7-year-old probably can cooperate with most of the exam. Okay, who wants to take a stab at reading these? Firstly, is the patient mature, skeletally mature or not?
Immature.
Okay. And you guys may not know this, but something that may be good to, if you were doing a peds rotation somewhere, memorize the characteristic sequence of ossification of the ossification centers of the elbow, because that is something you will, every resident, and we'll get pimped on this. It's just a fact of life. So you can, even if it's not an elbow injury, you can still get a sense of the skeletal, you know, basic skeletal age of the patient by looking at the elbow. So what do you think about these fractures? Is it a complete fracture? Is it unicortical with plastic deformation of the other cortex? I mean, I guess it's tough to, this is not quite a student question, but these are things that are important to note because that can kind of guide your treatment and give you a sense of how difficult the reduction will be. So, you know, a plastically deformed bone versus one that's completely broken, it's a little bit counterintuitive. You think, well, if it's fully broken, that's worse. So shouldn't it be a little bit, you know, easier to reduce it if it's plastically deformed? Well, sometimes it's actually kind of tough to do that. And you know, a child is going to need to be, you know, a child should be sedated no matter what you do if they have a broken arm like this. But, you know, you always want to, you know, comment when you're reading x-rays, is it a complete fracture or an incomplete fracture or is it plastic deformation? That'll kind of make it look like you know what you're talking about. Diagnosis and plan. So, I think that, in a child, first and foremost, in a fracture like this, you want to get a sense of what their pain level and what is, and it's hard to tell, like, what is an appropriate level of pain. Sometimes it may not, in forearm fractures and lower leg fractures, the question is like, you want to make sure they don't have a compartment or a developing or impending compartment syndrome. And it's rare, but this is something you cannot miss. You cannot send a child home with that. And one of the best ways to determine that is, A, what is their pain medicine requirement, and A, how is it evolving with time? How is the child's exam evolving with time? So these are all things to keep in mind. Obviously, we have a diagnosis with, you see, two mid-shaft fractures here. And then the question is, what do we do about it? And are we going to reduce it? Is it okay to leave it like this? Do we want to reduce it? How do we want to treat it going forward? Maybe a little bit behind the med student level, but you probably ought to reduce this, and you probably ought to get the patient sedated, and you probably ought to immobilize the patient afterwards. And there are different ways to do that, but that's probably a little bit beyond the scope of what you guys are going to be learning to do. All right. Case number 3. So called by a medicine resident. So you guys will see in residency that sometimes some of the more, I don't want to say annoying, but less acute consults come from the floor rather than the emergency room, because the emergency room at least generally has a sense of, is something an emergency, or is it something that could be managed outpatient and you're just being consulted because the patient's in the hospital. But in patients with joint effusions, will often get called for to rule out infection. And basically they're saying, well, one of the frustrating things sometimes is you'll be consulted to tap a joint, as if you are the tap man and you're supposed to come and just do what do a service, rather than evaluating the patient for their knee swelling and trying to figure out what's causing it, rather than just, I need you to tap a joint. So history and physical are pretty important here. And they can clue you in kind of right away about what is likely to be causing this, and what is less likely. So if the patient has a history of joint swelling, if they have a history of injury there, if they have a history of pain there that's been more than a few days, these are all things that clue you into other chronic medical problems as causing the issue, as opposed to an infection, which is generally what they're trying to get you to rule out and treat if that's what it is. So you want to get a sense of the character of the pain, any history of drug use, any history of inflammatory arthritis, any history of gout, pseudo-gout, any history of trauma there in the past. These are all things to get a sense of in the history. So you do the physical examination. You want to check for skin integrity. You want to check for the amount of swelling. You want to check, is it symmetric? Is there a deformity to the joint? These are all things that you gotta, basics, and range of motion. Is the patient have pain with micromotion, or is the patient have a decent range of motion that's just stiff because there's a lot of fluid in the joint? These are all things that will clue you into the presence or absence of infection or other significant inflammatory arthropathy versus just an arthritic joint. Anybody want to take a stab at reading this? All right, so AP and lateral x-rays of the, I guess the right knee, probably. Tough to tell in the hospital whether it's going to be weight bearing or not, but in the knee, that's a very important thing to note, because weight bearing, and especially if the knee is flexed or not, and what angle the knee is taken at, can really change the amount of joint space that's visible. Ignore the fibella, although make sure to know what it's called, because you may get pimped about it. Soft tissue calcifications, vascular phleboliths. These are important things to know about, because it's important to comment on those, because you don't want to gloss them over, and they can clue you into the patient's vascular status. Obviously, you're going to see if there's joint space narrowing, if there's deformity. You're going to comment on those things later in the exam, but you don't want to miss other things like any sort of subchondral sclerosis or subchondral lucencies concerning for ABN or an osteochondral defect in a young kid. These are all things that are important to note, and carefully scrutinize the joint surface rather than just saying, well, the knee looks a little arthritic. Well, I agree with you, but these are things that are you really kind of want to, if you're trying to sound like you're thoroughly evaluating the X-ray, these are all things that are important to know. And then also, don't forget to mention the patellofemoral joint. And it also helps to comment on the quality of the lateral X-ray. So here, the lateral X-ray is pretty decent. The two femoral condyles are well superimposed. But if it's more of an obliquogram, then you may want to comment on that as well. So with this guy, your differential diagnosis may be somewhat broad depending on the examination. And it's always good on a knee swelling patient to have a broad differential. You can't really rule out septic joint unless, you can, it's much less likely if the patient has, a relatively benign exam, but if there's a history of immunosuppression, the patient has, HIV or they're on immunosuppressants, the examination and the cell count, if you aspirate it, may not be, reliable. So these are all things that you want to take into account when you're making your differential. And your differential diagnosis is certainly going to be influenced by your workup. So did you aspirate? Did you tap the joint? What's the range of motion like? How long has the pain been going on for? And what other possible inciting events in the history are there? And your plan, is going to be guided by what you think the differential is. And if you're concerned enough that the patient may have an infection, even if the cell count isn't that high, we wash out patients with cell counts in the 10,000s because they're on severe immunosuppressants, and the exam and the history are concerning for infection. So these are all things that just because the numbers don't quite add up, the history and the physical examination they can certainly play a big role in guiding your plan. So, in conclusion, I would say, take every consult seriously, and as a med student who's rotating, don't get complacent. Every patient you see is an opportunity to learn, and it's also an opportunity for you to demonstrate your competence and your knowledge, and it's an opportunity for you to seem like you are being kind of flippant, or you're not taking it seriously. And I think that as a student, that's never something you always want to come across as kind of just being humble. Even if you are knowledgeable on a topic, even if you know more than the resident or the intern about some specific topic, doesn't matter. Your job is to show up, and get involved, get engaged, and do your contribute to the team, because you're going to have plenty of time to do all these things, and you're going to have you have 5-6 years of training ahead of you once you get into residency. So your goal in your away rotations and in your rotations here is just to learn and further yourself, but also to help the team and contribute, because fundamentally residency is a team. It's a team sport, and if your residencies, if residents in a program don't work together, there's failure to have a sort of a collegial team-based atmosphere, especially in a small program. It's just a disaster. So you guys need to get started early, thinking about the team ahead of yourself, and how can I help my intern, my resident, with their workload? How can I make them look better? That goes a long way in terms of your evaluation and what the people think about you. So, and obviously, focus history, get the relevant topics. Don't talk about don't talk about things that don't matter. And then a thorough examination with pertinent positives and negatives, and then just know how to read an X-ray, and know why you may or may not need advanced imaging, and what that could lead, and what that could yield. For example, that distal tibia fracture. Classically, we're going to get a CAT scan of that, but we may not do it until the limb has been brought out to length with an X-fix and the joint has been stabilized. So when am I going to get a advanced imaging, and why? And then of course, keep an open mind with the differential, and know why different treatment plans work and don't work. Like why would I plate a fracture versus nail it, and or treat it closed? So know the pros and cons of everything, because oftentimes you may get asked about that. And even if it seems kind of silly, you want to know, why do we operate on hip fractures? Like, what's the point? So these are things that are really, I think, essential to to not forget about, and always be thorough and always know more than you let on, because it always helps to have somebody be able to ask you a question and answer it, and it makes you seem like you know what you're talking about. Questions?
I thought that was great, Dr. Coyle. That's a great way to put it at the end. You really know your stuff, and sometimes keeping a little bit of information in your pocket, that shows what you're doing and why you made those decisions is important. We talked a lot earlier this morning in one of our sessions about knowing what you don't know. And right now, when you're a novice, you don't know what you don't know. And as you add more and more layers, eventually you start to realize, okay, I know this and I don't know that. And you want to be able to distinguish that. And sometimes you can ask a good question so you can advance your knowledge. But have an effective and systematic way to understand how you're going to see consults and present them, and really trying to get yourself to the level where you're an interpreter or a manager as opposed to just a reporter is really important. You don't want to just go and tell everybody and let them make the decision about what's going on here. We want you to make the decision, whether you're right or wrong, and give evidence to support why you think that's the case. And that way you can learn a lot more from it. We spent a lot of time talking about that this morning with them in one of the live sessions on H&P. So I thought that was great. Does anybody have any questions to bring out to the forum? It's kind of overwhelming to think about it, but you actually will be seeing consults, starting next week. And you may be going with the resident, and you may be documenting for them side by side while they're seeing it. And you may want to, ask them, how you can be helpful with that task. And, as they gain comfort with you and what you're able to report and understand, they will ask you to do more and more. And what you want here is graduated responsibility. Okay. That was great, Ryan. Thank you.
You got it.
So we're not married to a timeline tonight, guys. If we finish early, we finish early. That's perfectly fine. We can talk about additional topics if we need to. But what I'm going to do is queue up the next talk here. And give me 1 second to get it set up in the background. All right, give me 1 second here. Oops, I got to start sharing first. Hold on a second.
All right, guys, I'm going to take off. Have a good night.
All right, thanks, Dr. Coyle.
Yeah,
Greatly appreciated.
no problem. Take care.
All right. So obviously it's not July 14, 2020, but not too far off by a year. So what we're going to chat about today, are you guys able to see all these annoying Zoom bars on here today? I'm going to try to get some of this out of the way here because I shared my whole desktop. Can everybody hear me okay? Just give me a thumbs up somewhere in the gallery.
Yeah, we hear you.
Yeah, great. Okay. So it's really important to start to understand when you think about management of these injuries and getting to that level where you can think about giving people, real advice about what it's going to take to recover from the injury. It obviously stems from the diagnosis, the injury itself, and then the extent of the injury. But what I really wanted you to kind of learn a little bit about, and this is going to be a kind of a cursory lecture on this, there's a lot more depth to it, is recognizing that recovery from injury requires an understanding of the context. Okay, so this was a talk that I adapted from a pediatric fracture recovery talk that I give to pediatricians. So they have a sense of how long it's going to take for their patients to recover from a fracture. But if I added to this list here, okay, I might add things like polytrauma, blood loss, medical comorbidities, how the patient is compliant with their post-op regimen, okay? What are the things that really influence their ability to heal from an injury? And yesterday in the lab, you got to look at some implants that help to stabilize a bone. And the idea is that that bone is being stabilized until the biology can take over, and the biology can actually supersede the strength of the implant. And eventually that's what we want to have happen. You want to be able to eventually remove that implant if you have to. Like we said last night, you don't have to. But the idea is for you to start to understand what the phases of healing are, what it's like to recover from orthopedic surgery or non-operative treatment of an injury, what can go wrong, what can go right, how you can enhance recovery. And having a basic background on that can really help you in understanding why we do the things we do. The problem with a lot of the rotations that you're going to be on is that you're going to see the patient treated acutely, but you may not get follow-up. But it's just as important to learn what may happen down the line. And you'll hear us asking fracture comments. So what are you going to do with that patient in 4 weeks? How long are you going to tell them it's going to take to heal? And a lot of the counseling that we do on a one-on-one basis is information that patient takes to heart. So, you're not going to give them an exact date. You'll be walking in 3 weeks. You'd rather tell them there's a range of possibilities here. Most people might walk by 3 weeks, but a small percentage may take 8 weeks or longer. Okay. So you really want to be realistic with setting expectations. And that's something that I think we need to be able to do effectively when we're going into a treatment situation. Is this going to hurt? Yeah, it's going to hurt a little bit, but I'm going to give you some pain medicine. I want to be gentle and we're going to do it together. We'll figure it out. Okay. Or if you're worried about doing it, maybe we'll put you to sleep for it. Okay. So you can actually help them manage their expectations appropriately. So when we think about actually fixing a bone, here you see a model of a bone where you have a couple screws going through it. Okay. And does everybody understand the difference between cancellous bone and cortical bone? So when I say cancellous bone, what part of the bone are you usually thinking about? Don't be shy.
The middle
I'll
of
give
the
you
bone.
What's that, Paul?
The middle of the bone.
So
The
cortical
orthopedic
bone is the
side.
middle of the bone. Okay. Cancellous bone has like a lacy network, is usually more the ends of the bone. So metaphysis and epiphysis. Okay. Do you remember those differences? Metaphysis and epiphysis? What's an epiphysis?
So closer to the end of the bone.
Yeah. So Akil, so the epiphysis bears cartilage, articular cartilage. Okay. And if you had a physis and a long bone, it's usually, the joint facing side of the physis. Okay. So it's a small zone, has its own blood supply in a kid. And, is generally fairly stiff bone, hard to fracture. So if you fracture, it's usually high energy. And you're going to see this in periarticular fractures around joints. Cortical bone is the diaphyseal bone. Okay. And its histology is very different. Okay. When I say the word Haversian bone system, and you think of those cool lamellae and, these vessels running up and down these cannuliculi. Okay. I'm probably stirring up all these radar, all these buzzwords from histology back when you were M1s. I'm talking about cortical bone, right? So cortical bone and cancellous bone can remodel, and there are actually complex signaling pathways that tell them to remodel in a certain way. Okay. But when you initially injure it and you have a fracture that you heal, do you form cortical bone immediately? No, you form in a disorganized woven kind of bone, but under weight-bearing stresses, because bone responds to weight-bearing stresses, and under the local biology of that area, it reestablishes a tissue that looks just like itself. Pretty amazing. Can anybody name another tissue in the body that if you were to injure it, repairs itself with a perfect copy of itself?
The liver.
Yeah. Is that you, Amr?
Yeah.
That's who popped up on my screen, but your mute was there. Yeah, so liver and bone are the only two tissues that really make perfect copies of themselves. Okay. You have myocardial infarction, you have ischemic necrosis of a muscle belly. It's replaced with non-contractile scar, right? Try to sew pancreas to pancreas, and that doesn't work, okay? What if you tear a muscle? Thankfully, muscles are really compliant and have accept a lot of strain. Their load to failure is incredibly high, so muscles usually don't rip. If they do fail, they fail at the muscle tendon junction usually, because they're an interface of two tissues with different forces, and these are biomaterials principles that you'll learn eventually, okay? But if I ripped a muscle and sewed muscle to muscle, okay, what kind of tissue is going to form, and we'll call it what it is, in a scar, okay, of muscle? Well, it's going to be this dense fibrous mass. It's going to be non-contractile. It's not going to have sarcomeric contraction. So you're going to lose contractile function. And if you sew a completely severed muscle back together, you should only expect about 50% strength from that muscle going forward. So really try to avoid that, obviously. If it rips off at the origin and you reattach it at the origin with a screw and get it back out to length, guess what? That muscle still works because you've damaged it at an area that can heal with a perfect copy of itself, the bone. So we rely on these principles in orthopedics to help restore mobility and function to people by understanding that bone heals with a perfect copy of itself, a bone. But it can be compromised if the bone's infected, osteoporotic. People who have diseased bone still generally heal with the same pattern in the same amount of time. A kid with osteogenesis imperfecta, when they have a fracture, their fracture still takes 6 to 8 weeks to heal. It's just the same crappy bone that they had before because their biology to lay down new collagen in that area is still laying down the same qualitatively abnormal collagen, right? So when we think about a bone healing, what we would really like to see to prove the bone has healed is that it's actually reconstituted its native form. And in the case of a diaphyseal bone, as you see in the cross section here, that's going to be a reversion system in the cortical bone on the outside. And inside, it's fairly hollow. Now, someone implied earlier that that's cancellous bone in there. But what actually lives in that space in the bone?
Marrow.
Yeah, bone marrow. What does bone marrow do, Amr?
Hematopoiesis.
Right. Okay. So are your femurs making red blood cells as we speak, Amr?
I think so.
A few, okay, but probably not in your femur. So in kids, because of the volume of cellular turnover and the volume of medullary canal available, quantitatively, there's not enough medullary canal to use selective bones to make the marrow. So yes, we make marrow everywhere in our body and have hematopoietic stem lines in our diaphyseal bone. In an adult, that's not the case though. Most of our blood is made in our flat bones. So our pelvis is the #1 source. That's why when bone marrow biopsies are done, they're done through the pelvis, right? The scapula, the clavicle, okay? And then to a minor degree in the long bones, but the flat bones are probably the most important, and even to some extent, the vertebral bodies, okay? So it's just something to keep in mind. And remember, bone is also the vast reservoir of calcium and phosphate in our body, and it's tightly regulated by hormones like what hormones can influence deposition or extraction of the mineral salts of bone.
Parathyroid hormone, calcitonin.
Yeah, so calcitonin indirectly influences it by affecting PTH. But what does PTH actually do, Justin?
So it has like 3 major mechanisms of action in the kidneys, helps reabsorb calcium, and then actually you urinate phosphate. So you excrete phosphate in the bowel on the small intestine, helps reabsorb calcium and phosphate, I believe, as well as also back in the kidneys, stimulate the hydroxylation of vitamin D to the active form, I think. Right.
So PTH does have those functions, and they parallel a lot of functions specifically that are vitamin D functions, because some of those you named, they're vitamin D functions, okay? But PTH is a potent activator of the osteoclast. And what does the osteoclast do? Through the Rank-L ligand, which is a basic science concept that, they talk about. PTH actually stimulates your bone to release calcium and phosphate into the serum at a high level, okay? So PTH is upregulated when phosphate or calcium get low, and that can occur in renal wasting states like rickets, okay, where the kidneys are not processing phosphate well. So you're peeing out phosphate, you lose some calcium in the flow because of the cationic exchange. Your serum levels get lower, more phosphate than of calcium. So your body upregulates PTH to get more serum calcium and PTH. And the severity of the effect of a metabolic disorder on your bone is related entirely to the relative hyperparathyroidism. So PTH being elevated in your body, not necessarily a good thing. Okay. So why would we give PTH hormone to someone with osteoporosis? Well, because they need help with mineralization. If you supplement them with the calcium and phosphate they need and give them PTH, it actually helps to increase and help bone remodel appropriately. Okay. Calcitonin has the opposite effect and helps to downregulate calcium in the serum. PTH may go up in response to that too. But vitamin D and PTH probably regulate the reservoir of calcium and phosphate in our bone. And compared to the levels of serum phosphate and calcium, bone has about a 99% greater reservoir of calcium and phosphate than the circulating levels of those salts. So you have a lot of reservoir, but if you're losing calcium and phosphate for whatever reason, cancer, rickets, you name it, PTH will go up and your bones will get osteopenic as a result, and you can wind up with fractures. Okay. The way that bisphosphonates prevent that from happening is by poisoning osteoclasts. They look like phosphate, and when they get inside the osteoclasts, it actually shuts down some of their microtubule function, so they can't digest the adjacent bone and exhibit their effect. So the bone stops remodeling in a catabolic direction, and with this catabolic effect, you start to have a problem. Catabolic effect, you start to have the problem with the bone not remodeling enough to be strong, because bone remodels in response to stress. So when I have someone that I fix a fracture on for a few weeks, 6 weeks maybe, I want the bone to be protected from weight bearing so that my implant doesn't fail. Once my bone is strong enough to share the weight of the implant and I start putting weight on the bone, the weight bearing stimulates the bone to remodel faster. And remodeling occurs in a balance between bone deposition and bone resorption in all the right places. And so if you are poisoning the mechanism of osteoclast function with bisphosphonates, you will build bone density by laying down more mineral and not taking it away. But eventually you will sacrifice the stronger architecture because you can't remodel on the resorptive end, and you wind up with bone that, although denser, is more brittle because it doesn't have the architecture. So it's not just the mineralization, it's the architecture that matters, okay? Excuse me, guys, I have to answer something. So when we look at cortical bone, we see this classic histologic arrangement, okay? In metaphyseal bone, we see a more spongy bone, okay? And when we put implants into these bones, the implant type is actually different. So if you go back and look at the screws here, a screw in the cancellous bone has a larger pitch on the thread than on the cortical screw. The blood supply in a bone is both a high pressure system and a low pressure system. The nutrient arteries penetrate through a little foramina into the bone and circulate in here at a higher pressure than the circulation in the periosteum. Periosteum is intimately associated, as you guys saw in the lab today, with the surface of the bone. And when you strip it off, you take that away. That's why you want to limit how much stripping you do, and only over the areas that are necessary. And if you can put your implant on top of the periosteum, sometimes that's favorable. But when you injure a bone, oftentimes the intraosseous supply is disrupted, and there is a shift based on the physiologic process of inflammation to where the bone actually gets more nutrition from the outer third circulation, which is the periosteum. And this is why it's really important not to strip all that periosteum off to protect it, okay? When we put too much pressure on a bone and it fractures, the bone loses continuity. So this is where the stiffness of the bone in response to the loads applied to it exceeds what it can do. Does anybody know, if I gave you 3 modes of loading, compression, 3-point bend, and torsion, which of those is the bone most likely to fail in? So it's torsion. Your bone is 40 times stronger to compression than it is to torsion. So many fractures are twisting or bending injuries as opposed to pure compression injuries. And that's why we fail. The soft tissues around the bone also are injured. So when you have a fracture, you can't think of this just as an isolated bone injury. You have to think about this as a soft tissue injury of everything else involved inside there. And that's the stuff that swells and can become a problem, okay? And you can have continuing damage if you have a displaced fracture. When blood vessels are disrupted, you can actually get necrosis of the bone in certain areas. And you all could probably name a bone for me that has end arteries inside of it, that if it fractures, you might cut off the blood supply of a portion of that bone and may not heal because it doesn't have the blood flow it needs. What am I talking about?
Scaphoid.
That's right. Good job, everybody. Okay. So when we think about healing, okay, we think about fractures, there's lots of different types of fractures, and we should know how to describe these. And Dr. Monica will probably talk about this a little bit more tomorrow, but some of the different types are transverse, oblique, and spiral. And these are produced by the different force patterns and the rate of load. How you injure a limb, if you fall on an outstretched hand, you could fracture your wrist, you could fracture your forearm, you could fracture your elbow. And it all depends on the rate of load and the force applied. And then where that force tends to concentrate, maximize, and fracture. Transverse fractures tend to occur by a 3-point bending mechanism. Oblique fractures by a twisting injury that's rapidly applied. Some 3-point bends can do that. And spiral is more slowly applied. This is kind of the slow motion fall where your leg gets twisted and you get a long spiral like that, okay? Fractures can also be described as impacted, like the one here, where the tibial plateau is impacting it, or comminuted. Dr. Coyle touched on some of this. But what I really wanted to get into is the healing part, okay? So when a bone is injured or soft tissue is injured, okay, what's the first thing that happens? Well, you're disrupting blood vessels, so you get internal bleeding. And that internal bleeding is rapidly stopped. What are some different pathways your body has to stop bleeding?
Clotting cascade.
Clotting cascade, okay? So the clotting cascade tends to work in what situations? There's an intrinsic and extrinsic, right?
Like in terms of injury?
Yeah. So if you have acute phase reactants and complement going to an area, you know, it might help to stabilize or bind to blood vessel walls, okay? But if you have endothelial injury and you have exposure of endothelial tissue with disruption of micro blood vessels, what other mode of coagulation probably helps to get that to heal? If you had exposed tissue, what would be the more likely mechanism to heal? It's platelets, okay? So platelet degranulation is an incredibly powerful chemotactic event because when platelets agglutinate in response to calcium, you get a huge amount of release of cytokines that recruit other cell types to the area. That's inflammatory, okay? So a fracture hematoma forms and stabilizes, and its chemotactic response over a couple of days, as you see the Venn diagram, overlaps with the inflammation phase, okay? The inflammation phase is fairly acute, and it's recruiting new types of cells to the area to get it to heal. So we're recruiting what types of cells? So we have a fracture of the tibia and we have an open wound. So grade 3 open tibia fracture. So if I release cytokines, what's that going to do around the bone? How is the bone going to stop bleeding? How is that area going to stabilize? Well, it's going to recruit cells that are of an osteoblastic lineage. It's going to recruit cells of a fibro and chondroblastic lineage. It's going to recruit cells of a macrophage lineage. And each one of those has a purpose. And the cytokines are going to help those cells get in there, because when you have an inflammatory phase, I'm going to jump ahead a little bit here, and we're going to come back to all this. Okay. When we have inflammation, okay, what does inflammation mean to you? Well, all these things, okay? So someone has an infection, you know, you might have fever and proliferation of white cells. Guess what? A fracture hematoma leads to fever too. Why? Because it's the same interleukins. But basically you get capillary leakage, release of tissue fluid or plasma distillate into the peripheral space, and you also get migrations of cells because of the chemotaxis into those peripheral tissues, okay? And platelet degranulation is probably one of the most powerful attractors. And once you get interleukin 1, interleukin 5, and interleukin 10 involved, those retract other tissue types to the site, okay? And if we go back here and look at fracture healing, in the beginning, we just form a clot and we stabilize that. And if you put a splint on them or you put a cast on them, you're going to help to stabilize that. If it's an open injury and you wash it out, you're going to evacuate all that clot. But when you close that wound, they're going to form another one. Okay. So you're not resetting the clock too much. If you wash it out 3 weeks afterwards, you might be actually setting back the machinery of healing. You got to think about that. Okay. But basically, a blood clot forms from tamponade. Periosteum helps to hold it in. The adjacent tissues help to hold it in. There are going to be areas of the fracture that are cut off from their blood supply because the trauma is significant. The high pressure system inside the canal is cut off, and the vessels from the periosteum are stripped as well. So you will get some local necrosis, and you actually might see the fracture gap widen at the first x-ray at 2 weeks because of that local necrosis, okay? But macrophages are going to get recruited in. They're going to start digesting some of the cellular debris, the fibrin crosslinks that are coming from the platelets, and you're going to get growth migration in there of fibroblasts, chondroblasts, and osteoprogenitor cells. And they're each going to be signaled by the adjacent tissue types to start going to work and laying down a matrix that will first be a fibrous matrix, and then a chondroid matrix, and then an ossified matrix. And that process takes a couple of weeks. And it's going to work better if there's better blood supply and better stability. Imagine this was unstable and kept moving. You're going to keep disrupting this process here. And eventually the body could give up and you could wind up with a non-union. So that's why immobilizing fractures or stabilizing them with implants is really important. As we get into the reparative phase, now you really start going to work, and you see cells of lots of different types here. The monocyte lineage and the macrophages are digesting stuff. They are actually starting to change into sometimes some osteoblasts to resorb the bone here. That's what the red giant cells are here, okay? Some chondroblasts and fibroblasts are forming a matrix that can be digested later and form bone. Then your osteoclasts and osteoblasts start to work together to cut away some of that tissue and start laying bone down. And new blood vessels are recruited through VEGF to invade into that area and bring blood, because this is a highly energy dependent process. And if there is no oxygen being delivered to the area, it can't work. All right. So new blood vessel growth is critical to this reparative phase. And then once we start laying down a more organized matrix, what do you think this would look like on an X-ray?
Callus.
Right. So this is what callus looks like. And callus is usually wider than the existing bone. Okay. Now, what's interesting is that bone strength is proportional to the radius to the third power. And this is disorganized, but a larger callus actually gives strength relatively quickly. And when you apply weight to this, when you feel like there's a connection, you actually stimulate this to remodel further, because what's kind of cool about bone is that when you load it, it develops a positive or negative micro or piezoelectric charge. And a negative electric charge leads to bone deposition, and a positive electric charge leads to bone resorption. So it can actually tell where the load is being applied on the right side or wrong side of the bone and rebuild exactly what was intended from the substrate here. It's really cool what can happen. But ultimately, the goal is that we're trying to restore the medullary canal and the cortex. So when do you decide that someone is healed? Well, is it when you wait until the medullary canal is reformed? The answer to that is yes, in some big diaphyseal bones like the tibia and the forearm. But the answer to that is no in metaphyseal bone. Once I see good callus and they functionally can walk, I let them walk. And the beautiful thing about the body's feedback is that if you tell a patient, hey, weight bear is tolerated, it's okay for them to do. Weight bear is tolerated. Are they going to try to go run and jump? No, because their body's going to give them feedback that that's too much. Your body can sense, hey, I can't handle that load right now. So it is actually okay once you get a relative amount of stability to allow the person's rehab to progress to weight bear is tolerated, which means do what you can and listen to your body. How long does that take, guys? Ballpark. There's a great number that should be out there in your head. 6 to 8 weeks. Okay. Kids shorter, smokers longer. All right. If you don't see callus on the x-ray, you should be a little worried. Maybe you're going to a non-union. You had more necrosis at this site than you thought. But once you see callus and they can functionally bear weight, let them go, especially if you have a device in there that's sharing the load. And for most people, that's about 6 weeks. Now, why is the ulna, scaphoid, some of these other bones exceptions? It's usually because their blood supply is a little bit worse than some of the other bones. They don't form the callus as robustly as you would want. Okay. So bone healing kind of looks like this, all right, in its phases. And basically, once it remodels, like you see in the bottom right corner here, there's no more scar, if you will. Okay. It has remodeled the scar into a bone. And you don't have to wait, because that process could take a year or two to finally get back to looking exactly like the bone before. And yeah, there can actually be deformity sometimes in a bone, but still be completely healed with cortical bone that's reformed. Okay. And as I told you this morning, that is the bone healing really depends on two things: the stability of the fracture and the bone heal and the blood supply. Now, I mentioned yesterday, and it might have kind of escaped some of your attention, that if you do rigid compression with a locking plate or a compression plate where the plate slides and squeezes the bone ends together as hard as you can, you may get absolute stability of those fragments where it is practically as strong as it was before. And you may actually get bone healing that looks like this. Now, this is called a cutting cone here. This is a new blood vessel that's migrating into a bone. You can see a little crack right there that's being compressed directly. And this cone has osteoclasts at the tip, pericytes, which will become capillaries as they migrate in and develop an endothelium. But this will literally cut across the fracture with osteoclasts and then have osteoblasts come in behind it and lay it down. And you will see no callus. It's actually harder to read the recovery of these, but you have to believe empirically with compression plating that once you see some reconstitution of the medullary canal, or if you can get a cross-sectional, a tangential x-ray of the cortex at a level where the plate isn't blocking and you actually see that it's linked and the gap is gone, that fracture is healed. It is rigid, okay? So this only occurs if you get rigid internal fixation, and that's called direct bone healing. So we didn't talk about this in the lab yesterday, but say this red line is a fracture line. If I put a screw into that hole and I am directly perpendicular to the fracture and I drill, when we drill for screws, we drill for the diameter of the inner part of the screw, not the planes that stick out. And if I drill a hole in this that is exactly the right size for the screw to bite on this side, but then I drill a hole that is as large as the threads on this side, when this grabs this cortex and the head compresses here, this bone will squeeze together directly and have absolute stability. So in the ankle fracture depicted here, I could put a lag screw through the plate or a lag screw through the fracture and hold it, and then just lay my plate on and it heals. And that gives you direct healing. Compression plating and lag screws can do that. Indirect bone healing is almost all other bone healing, okay, except in some pathologic states like Paget's disease, certain types of tumors. And usually we have relative stability here. So this might be an external fixator. This might be a nail where there's some weight bearing. And generally that big hematoma that radiated out from the center of the canal will ossify, will fibrify, made up a word, chondrify and ossify in sequence. And you'll see that callus being larger than the diameter of the canal. And that's the bone callus. And you can see that depicted on this ancient x-ray down below, okay? This relative stability forms very strong bone. That's greater than the diameter of the actual bone. So it gets strong pretty quickly because of that. And whether you have direct healing or indirect healing, these are the types of things you want to see. And the real principle I want you to come away with today is, how long does this type of thing take? So if we jump ahead, I'm going to come back to these slides at the end, okay? What are general healing times for the different types of injuries, okay? So a patient comes in and they have an exercise muscle soreness, delayed onset muscle soreness. I have had kids come to the office to me and the parents saying, all of a sudden they have all this pain, and they show you where, and it's like the musculotendinous junction of the brachialis, and you're already getting suspicious. So what were you doing a few days ago? Well, I was weightlifting, okay? Well, when did it start to hurt? Yesterday, okay? Well, when you're weightlifting? Well, 3 days ago. You have delayed onset muscle soreness, okay? I'm sure you've all heard of this, and this is something that's going to go away. And if they exercise for a couple of weeks, they'll no longer get it because their muscles acclimate, they prepare, they have better glycogen stores, their mitochondria are better producing ATP without having developing fatigue or anaerobic glycolysis, and so that muscle doesn't get quite so sore, okay? Now, if I strain a muscle, which means I stretch, when I say strain, what structure is injured? Is it a muscle? Is it a tendon? It could be either, okay? But a strain is the word we use as a technical term to semantically describe an injury to the muscle tendon unit, muscle, tendon, both. Sprain is the term we use when we injure a ligament, okay? And those are all graded based on the severity of the injury, where a 3 is complete disruption of the structure, and a 1 is a stretch of the structure, and a 2 is somewhere in between. And you can see a vast difference between the rate. I know this is kind of small, but muscle strains get better quickly, especially with rest. Ligament sprains, they can take longer, okay? Generally, an MCL sprain of the knee, 3 to 6 weeks, okay? Now, what if you sprain another ligament known as the ACL? Can you do that? Yeah, well, a grade 1 sprain is just stretched and hurting. A grade 3 sprain, that's an ACL rupture, okay? So we have to understand that nomenclature, and that's not getting better without reconstruction, right? If I rupture a tendon, okay, I could have tendonitis if I strain it, tendinosis if it's got some chronic changes, and a laceration could take quite a bit longer to heal and probably needs immobilization and not being pulled on in order to heal properly. If I fracture a bone, depending on blood supply, it could be a few weeks to a few months to heal completely. If I repair articular cartilage and put it back with a bioabsorbable screw or a headless screw, that's going to take much longer to heal. And I have to really evaluate my imaging carefully to see that. And if I graft a ligament like a hamstring or an allograft Achilles as an ACL graft, or for any other type of interposition graft, or if I'm augmenting a flexor tendon repair, I really have to think about how long it takes for tissue to heal the tissue. And tissue healing, okay, when you think about bone, it's not that different, okay? So wound healing in a tendon or in a skin wound or in a muscle is dependent on the same inflammatory cascade. Platelets, basically forming a platelet plug where you have microvascular injury. The degranulation and cytokine response brings in other cell lineages like neutrophils, monocytes, and macrophages, okay? And then later on, you get other types of cells that come in and give you stronger tissue. Keratinocytes are responsible for healing your dermis. Tenocytes will differentiate from mesenchymal tissue to heal tendon, okay? So there's an activation of these pluripotent cells of different lineages. And remember the lineages, when I say mesenchyme, that is mesoderm, okay? Most of the tissues we treat in orthopedics are mesenchymal tissues, okay? Mesoderm. So when you hear the word sarcoma, sarcoma is a tumor of mesenchyme, whereas carcinoma is of ectoderm. Make sense? So squamous cell carcinoma, lung cell carcinoma, the lungs form from invagination of ectodermal tissue, okay? It all goes back to embryology. I told you guys that yesterday, okay? So we are talking about tissues that are mostly mesenchymal in origin. And so these pluripotent stem cells will be mesenchymal tissues. And if I'm healing a muscle, I may have myofibroblasts come in. Okay. So each tissue type takes time. And just like with bone, the amount of blood supply impacts it. So what's the longest thing to get to heal here? Ligament graft, because this might be allograft, and it has no blood supply. So the blood supply has to grow in from the bone. And that does happen. And you eventually replace all the cells in that graft with living cells, or all the material in there, you get an invasion of tenocytes. Articular cartilage, is that well vascularized? No way. How do you get oxygen to your articular cartilage cells? Diffusion from the joint fluid. All right. Where else do you rely on diffusion? Well, if you're a bug, probably. Okay. Bone heals quickly because it has good blood supply, except things like the tibia or the scaphoid. Tendon doesn't have great vessels running through it. That is a solid white structure. Okay. But a muscle has got a lot of stuff running through it. So it'll heal quickly, but it heals with a bad scar. Okay. Whereas a tendon, the tenocytes are low oxygen requiring cells. They have poor circulation there. Articular cartilage is a very low PO2 and can survive there without oxygen for long periods of time. So when you have avascular necrosis of the hip, the bone collapses, the cartilage is usually okay, but the cartilage without a substrate underneath will sink and subside, loses congruency, and then you have a problem. Okay. So the rate of healing, again, goes back to stability and blood supply. Now let's look at the healing of the skin a little bit. Okay. So if I had a laceration in the skin, whether it's an open fracture, any type of open wound, we do dressings, right? So a skin laceration heals with a blood clot. Okay. A scab forms and acts like a bioocclusive bandage to this area, keeps the area from drying out because that'll kill the cells on the top that are trying to heal. Okay. And what'll happen is eventually that scab will fall away, but it will wait until you have an adequate repair of the tissue here where there's tension to prevent it from falling apart. And you have granulation tissue that will gradually fill the wound and the defect, and then remodel to restore soft tissue tension. Does anybody know how long it takes with a suture repaired laceration of skin to restore 95% of tensile strength across the wound? So pulling the wound open, 95% tensile strength. Hazard a guess?
I guess a month.
6 weeks, Will. Okay. So that was a good guess. So it's kind of like bone. Bone heals fast too. And why does skin heal so quickly? It's got a good blood supply. Okay. Now, what happens if you have a wide gaping wound and you can't get the skin edges to be in contact? What happens if we have a wound that's bleeding underneath? How well it heals actually depends what tissue is underneath there. And this actually impacts how we treat open fractures. So if I have an open fracture of my tibia, and that fracture is in the proximal third of my tibia, there's a pretty good soft tissue envelope in there. That may heal pretty well. If it doesn't heal, the skin injury that is, I can swing a flap of the gastroc, medial or lateral, into the wound to help get it to heal. And because the muscle has a really good blood supply, I can lay skin graft onto that muscle to heal. If I have a distal third tibia fracture, how's my soft tissue coverage anteromedially when the tibia pokes through anteromedially? Everybody touch the distal third of their tibia. What muscle's there? Medially. Nothing. And how much can you swing a muscle over? Nothing. Okay. So distal thirds, can I lay a skin graft directly on bone? No. If bone has periosteum, does it have some blood supply? Sure, but the bone's robbing most of that. If I have exposed tendon, does the tendon have a blood supply for vascular ingrowth into a skin graft from a tendon? No. Okay. So if you have to heal a tissue bed, what you put into the tissue bed and how you try to fix it really depends on what's at the bottom of that tissue bed. Now, there are a ton of biologic augmentation and artificial products that we have now, being collagenase to break things down. And you can get skin to grow over a bone if you treat it well enough. Okay. We have VACs to help stimulate at low pressure, granulation tissue to form, the negative pressure of about 125 millimeters of mercury helps to stimulate the cells to be more active. And we can help a wound heal from the inside out by applying that negative pressure. But if a defect is difficult to close and we have to transfer tissue into the distal third, I don't have a long soleus flap or gastroc, because at that point, that muscle's become a tendon, and that tendon doesn't have blood supply. Now, there's sometimes some turn down flaps, but they look really ugly on your leg and you lose a lot of function. So what might I do if I had a large soft tissue defect to repair in the distal third of the tibia? Anybody? Free tissue transfer. So I might take a piece of tissue with a blood vessel and sew an anastomosis into the blood supply, posterior tibial, anterior tibial. Posterior tibial is a little bit bigger there, and actually bring a piece of muscle into a space and skin graft over that. Okay. Now, if I have a good healthy base and the wound defect is not too big, say less than 2 square centimeters, can I get that to heal just by putting bandages on it? You betcha. Okay. So what are some different types of bandages that we can use? Well, a deep wound that we're worried about an infection and we want to try to let that wound clear itself out and kind of express all the negative stuff. We can put drains into it. We can put packing into it. But if we keep packing a space, we're not actually going to let it heal back together. Once you get a space to kind of close down and you want it to heal by secondary intention from the bottom up, we frequently use wet to dry or damp to dry dressing changes. And the reason that you'll see us do that is because you apply that bandage damp, you apply a dry gauze on top of it and then wrap it, and you change it twice a day. And when you peel off that dry gauze, the dry gauze will have wicked most of the moisture out of the wet gauze, and now it's become slightly adherent to the tissue. So when you peel it away, you take the unhealthy avascular cellular debris of the most superficial part of the wound, and you continue to stimulate that uppermost wound to lay down new layers of tissue and actually level out the wound and grow from the inside out up to the skin level and form skin. How does it know when to form skin? Well, it starts to get signal from adjacent dermis and epidermis that, hey, you're superficial enough, start forming skin. Body's pretty smart. It's pretty remarkable that our body can do that. But you see a lot of other lists of things here that can help. Abdominal binders and Montgomery straps are ways to kind of keep bandages on that you have to change all the time. Electrical stimulation, I don't have a lot of experience with, but it can help. And the VAC is amazing. And now the biologics, using artificial skin, using collagenase, using hydrocolloid gels that really help to maintain isotonicity with the tissue, can really help to stimulate them to heal as well. Okay, if you let them dry out, the cells in that tissue die, and now you've lost that upper layer and it just has to fall off and go to the next layer. So that's why we don't frequently do dry dressings to these areas. Okay, so getting wounds to heal really means understanding what is the process that's going on here and how can we help. And when do we know that we're not getting there? Well, if the wound's getting infected, we probably need to clean it, and we probably need to give some antibiotics to help the immune system win this area over. But if the wound is healing, we can just keep doing what we're doing and get it to where it needs to be. Now, an external fixator, like you see in the picture here, has very little effect on the blood supply of the bone because you're only violating in certain places. And believe it or not, this is a great way sometimes to address a complex fracture. Say a comminuted segmental fracture with bone loss. How are you going to hold it out to length? You put a nail in it, it's going to shorten on the nail, and you're going to have a big defect in the bone, and you have this large soft tissue defect. Well, an X-fix is sometimes a way for us to manage all of those problems by holding a bone out to length and allowing the soft tissues to quiet down and do some work without having a device under there that has to heal also, because the metal device in there definitely has no blood vessels in it. It's worse than the bone. So laying a skin graft on a plate doesn't happen, okay? If you have a fracture that is known to swell, or a fracture that is known to do very poorly if you operate on it acutely, an X-fix is the way to go to let the soft tissues quiet down. Can anybody come up with an example for me? So a tibial plateau or an ankle pilon fracture, Dr. Coyle talked about one in his talk. Those fractures, notoriously, if you make incisions on them a day or two after surgery, because that inflammatory cascade and swelling effect is so strong, you're going to close that wound. And because the skin over there is tense, it's just going to swell and blow itself apart and expose your hardware. You don't want that to happen to you. So you'll see us use external fixation to hold that tissue for a couple of weeks. And you probably have up to 3 weeks to replace that with an internal device without worrying about infection. Okay, so if you have a bad open grade 3B open tibia and you want to stabilize it, and X-Fix is a quick and efficient way to stabilize it, allow soft tissue management with a vac, multiple returns to the OR for debridement, et cetera. And then you can actually go and revise that and take the X-Fix off, perhaps when you're getting your soft tissue settled down, and now place an intramedullary implant to stabilize it. So X-Fixes really allow us to manage difficult situations, and they can be used as definitive treatment. But if they're too rigid and don't allow the bone edges to move, you can actually have a problem with being too stiff, and the relative stability is actually too much, and you don't heal because the bone edges aren't touching and loading each other. So you have to be careful about that. That's kind of a more advanced concept. Okay. What I really wanted to get to tonight was this idea of how long it takes to heal. Bones usually take 6 weeks. Soft tissues, 2 to 6 weeks. Minor things that don't hurt that much right now will probably be better in a couple of days. So when you start getting those phone calls from your friends soon, and I told you they'd be coming, and they say, I sprained my ankle, can you walk on it now? Yep. Well, it'll feel better in a short time. Can you walk on it yet? Nope. Go get it checked out. Okay. So understanding how long it takes to recover from an acute injury and knowing whether it's a real problem or not also has to do with this timetable. Okay. So you really have to kind of think that through. All right. Any questions from you guys?
For the external fixator, how are you allowing any mobility for the fragments? I didn't really follow that part. If you're pinning through the bone, how do you still let it move?
Say again, Will.
I was just asking about the external fixator. So you're saying that you still want to allow some play for the bone fragments to still be in contact?
Well, the fact is that they can be fairly rigid depending on how you orient the pin. So there's a whole concept, and we'll talk about it later on in the summer, about applying external fixators and how rigid they are. And it's related to the size of the pins, the spread of the pins that you use. I got to plug in, guys. Sorry. And my kids are on the television. They're almost done. Hey, guys, can you turn the TV down for a second? And now my phone is playing Pod Save America. Sorry. They did it for a very personal. So this external fixator would not have a huge amount of stability. So those fracture ends would be able to move. But if I put a circular external fixator on with multiple pins and multiple planes, that can be rigid enough that it doesn't heal. And so that's the other end of the spectrum. And you'll hear us talk about that in conference. I tell you to know that it exists as a concept, but generally an external fixator, especially one like this, applied quickly. You know, if the patient's an extremist in the OR and general surgery is doing next lap, you can put this on in 10 minutes and stabilize their femur fracture and really help the patient and stop the acute blood loss that they have into their leg or into their thigh, especially in the femur, without having to go through a 2-hour operation if they're really unstable. So it's a tool, and that's the way to think about it. And you can do too much with it. That's probably out of the scope of what we get into today, but that's the concept.
I have a question about looking at bone healing on a radiograph. So apart from kind of thinking about like the timing of injury, can you actually tell by looking at a radiograph, like the stage of a soft callus versus a hard callus?
Soft callus, you can't really see, Danica. So how soon, guys, on average, would it take, and Dr. Monica will probably cover this tomorrow, how soon would you see hard callus of any type, calcification, showing up on an x-ray after a fracture? Acute.
I think usually greater than 3 weeks.
2 weeks. Okay. And I deal with kids, so it's certainly on the lower end, but in a tibia, it might take 4 weeks or 6 weeks because that blood supply isn't so good. Okay. So it does again relate to the rate of healing, but it's on that Venn diagram and overlap between those different inflammatory and reparative phases. Okay. So when you start to get ossification of chondroid tissue or fibrous tissue, that's really when the bone formation is starting. Those are osteoblasts going to work. Okay. But they are not organized enough to really form cortical bone. But in a well-organized, stable fracture with good blood supply, you could really start to see that reorganization happening fairly quickly. Okay, but usually 2 weeks is the earliest time you'll see callus.
Okay, thank you.
Sure. So just some principles for thinking about this. Okay, so this gets a little bit basic science-y. I love basic science if you guys can't tell.
But it's really important to think about it, but it gives you a framework. So if someone asks you, hey, how long is it going to take me to feel better? Well, the answer is it depends. Okay. If someone can bear weight now functionally, do you think that it's going to take much longer for them to get back to bearing weight? No. But if architecturally their bone isn't ready, their pain from that instability is going to give them enough feedback that if they injured their ankle 5 days ago and they're still not walking on it and they can barely, move it up and down, they ought to get checked out. Okay. Or, deformity is an obvious thing. Okay. Or I can't move my elbow, or my kid broke their elbow, or my kid fell on their elbow and now they're not moving it. Well, how many days has it been? Well, it was yesterday. Okay. Well, give it a day, give it 2 days, see what happens. How long ago was it? A week? If they still can't move it, you have a fracture, go to the doctor. Okay. So that's the kind of context you guys want to put it in. It's all relative. Orthopedic relativity. All right. So I want to thank you guys. We'll wrap up a little early tonight. Tomorrow night, Dr. Monica is going to talk about x-rays, interpreting x-rays and advanced imaging, and we'll have some fun with that. I'll log in. But I want to thank you all for your participation today. I thought the lab this morning was awesome. And, I recorded these talks, and we'll find a home for them somewhere. I'll divide them up into the 2 talks between me and Dr. Coyle, because it's like an hour and 42-minute recording right now. I don't know how many gigs that is, but that's a lot. But we'll find a home for it. And I'll actually have you guys kind of direct me to where you think you want it to be. Do you have a Google Drive or Share Drive somewhere in med school that you guys use for articles or things like that? Not really. So we'll find something. Okay. We have kind of a common department drive, and maybe we can make a med student section and give you guys permissions in there and share it, but I'll figure that out this week. Okay. All right. Great to see you guys. See you tomorrow evening. All right. Thanks for everything today. Go enjoy a pleasant evening. Okay. Thanks.
Thank you.
Thank you. Thank you.
Thank you.